Hey guys, I apologize that I am not present today. I have a CSR session and I did not realize that I was also teaching you guys. So I'm going to go ahead and record my lectures. I wasn't able to figure out how to add the slides, so I'll just kind of go from each one. I'll tell you what slide I'm on. And if you have any questions, feel free to email me. My email's chenson, henson, at mfa.gwu.edu. So I'm going to go ahead and navigate to the PowerPoint. You guys will just be watching me. It might be good just to be listening to me, but bear with me here. All right, so I'm on slide 2 now of the diabetes lecture, just kind of going over the objectives. So diabetes is a pretty complex disease, and it's very important to know how to manage it from the primary care perspective. So anywhere from preventing it, diagnosing it, understanding what prediabetes is, and then also kind of getting into management and really how far you can take it as far as a primary care physician really varies from person to person on your comfort level and your experience. So slide 3 talks about who to screen, and for your exam, I know that you guys are supposed to know the USPSTF guidelines. And they really have kind of easier ones to remember. So really anyone who's 40 to 70 who's overweight or obese, you're going to need to screen. The ADA actually has a little bit more extensive guidelines, which I think I tend to follow a little bit more in practice, where they say anyone who's over 45 should be screened. And you should start earlier if they're overweight or obese and have one or more additional risk factors. So things like that are going to be like if they have known history of prediabetes, they have a family history, if they're a high risk ethnicity, which they consider to be African American, Latino, Native American, Asian American, and Pacific Islander. And then for those who want to go into OB, people who have had gestational diabetes or PCOS, hypertension. We used to have different goals for folks with hypertension for their diabetes control. And then some other ones too, like physical inactivity and other conditions associated with insulin resistance. And then in kids, they usually recommend screening kids who are overweight or obese who have 2 or more of these additional risk factors. To diagnose diabetes, you can see here, you have to have a fasting glucose greater than or equal to 126, A1C 6.5 or higher, and a glucose tolerance test with over 200 after the glucose load. I put an asterisk there because you need repeat testing to confirm it if they're asymptomatic. But if they have symptoms consistent with diabetes, you actually only need 1 test to confirm it. Slide 4 gets into prediabetes. I don't know if you guys have seen a lot of patients with it. Hopefully you have had exposure to it. And that just has a little bit a lower standard. So if you have fasting glucose greater than 100, but less than 126, 2-hour glucose on the oral glucose tolerance test, 140 or higher, and an A1C between 5.7 and 6.4. That basically indicates that you have a risk of developing diabetes over time. And so the most important thing to emphasize for patients like this is that it's kind of, a good scare for them to start working on some of the lifestyle changes. There are 2 different proven strategies to prevent developing diabetes if you have prediabetes. One of them is metformin, which is a medication that has its own side effects. And then the other is the diabetes prevention program, which was like an extensive study. And they found that if you achieved a 7% weight loss, again, this was just research, and were able to participate in 150 minutes of exercise per week, you had a statistically significant reduction in developing diabetes over time. So getting into the primary care for folks with diabetes, the first thing you want to talk about are the things that could go wrong from the diabetes. So we usually break them into the microvascular and the macrovascular complications. So as far as the microvascular complications, we talk a lot about a blood glucose control. And so the lower your A1C, the lower your risk is of developing things like retinopathy, nephropathy, and neuropathy. And a lot of times people think of the stocking glove peripheral neuropathy, but there's also autonomic neuropathy, which can be anything like gastroparesis, sexual dysfunction. Sometimes people even have a lot of like lightheadedness because of their diabetes control. And then getting into the macrovascular complications, we think about addressing blood pressure and starting people on things like aspirin. So that's going to be the bigger vessels, so coronary artery disease, peripheral artery disease, and risk of stroke. So again, the most important thing on slide 6 here that we kind of address is we want to monitor really closely for microvascular complications. So in folks with type 2 diabetes, upon diagnosis, you should actually start them on annual screening for the microvascular complications. So that's going to be a dilated fundoscopic exam, usually by an ophthalmologist each year, doing a spot microalbumin to creatinine ratio for diabetic nephropathy. And for diabetic neuropathy, you should do a diabetic foot exam actually at each visit, which includes, inspecting for ulcers or tinea pedis, checking pulses, looking at their capillary refill, checking their lower extremity reflexes, as well as doing a monofilament test, and proprioception and vibration. Slide 7 talks about the macrovascular complications, monitoring and treatment. So for blood pressure, you want to monitor it at each visit. And your goal, according to the JNC8 and the ADA, is to have a blood pressure of less than 140/90, which is higher than it used to be under some of the previous guidelines. And I think the ADA still encourages blood pressures to be lower. So they actually say if you can achieve a blood pressure of less than 130/80 without undue burden, you should do that. So if they don't have any symptoms, you should go ahead and treat them to a lower goal. For cholesterol management, most people are going to benefit from a moderate to high intensity statin. You guys are going to get a whole cholesterol lecture if you have not already. So I would kind of defer to those, but as you'll see, most people with diabetes will fall into the statin benefit group. And then antiplatelet therapy. So it's recommended that most people who are at increased risk, including most people above age 50, be put on low-dose aspirin. As far as treatment of diabetes, probably the biggest thing that you can start off with is lifestyle management. So all people who are diagnosed with diabetes should have some sort of diabetic education incorporated into their treatment plan. So endocrinologists are great because they usually have diabetic educators. It's a certification that nurses and nutritionists can get to help teach people how to manage themselves. And so those are the first two things. And then you should actually refer them to a nutritionist and get them engaged in physical activity with the aim of decreasing weight. So evidence shows that a sustained moderate weight loss of 5% can improve glycemic control and decrease the need for oral hypoglycemic agents. Obviously, you want to tell them to stop smoking because of the risk of macrovascular disease. There have been some studies that show that diabetes is considered to be an equivalent to coronary artery disease, and that somebody who has diabetes and has never had a heart attack actually has the same risk of developing a heart attack as someone who's already had one. And then you also want to provide them with the support that emotionally that will encourage them to succeed. Okay, so getting into slide 9, immunizations are really important for people with diabetes because of a moderately compromised immune system. So everyone with a diabetes should get the routine vaccinations, as you will have discussed in your vaccination lecture. That includes annual influenza. And then they also are in the benefit range for the pneumococcal vaccination. So everybody, including non-diabetics, should get both the Pneumovax and Prevnar after they're 65. For people with diabetes, they also should get a Pneumovax, or the 23-valent PPSV vaccination, once before they turn 65. And they should also get a repeat again after they turn 65. Hepatitis B vaccination is also encouraged for people with diabetes who are younger than 60, and then it's optional after 60. And just to remind you, you need 1 year in between Prevnar and Pneumovax, and you need 5 years in between individual Pneumovax administrations. So slide 10 talks a lot about the different types of strategies that you can use to improve A1Cs. And so obviously there are a lot of different medications, insulin and other non-insulin therapies, but really lifestyle management can be huge in lowering people's A1Cs. Now here on this table it says that the decrease in A1C can be anywhere from 1 to 2, which if you compare it to all the other strategies except for insulin, it's actually one of the most effective. I've actually seen lots of patients who are highly motivated lower their A1Cs dramatically, even more than 2 points with lifestyle management alone. Getting to slide 11, the goals of treatment. For your future knowledge, so an A1C, the routine goal is less than 7%. But you may be more or less aggressive depending on the patient sitting in front of you. So if you have a young person who has a new diagnosis of diabetes, is really motivated and can achieve a goal of less than 6.5 without a lot of different agents, you probably want to go ahead and keep them at that way and be aggressive. Whereas folks who are older with more complications, particularly the microvascular complications, which are essentially not reversible, you may want to shoot for a goal of less than 8, because the risk of hypoglycemia is actually probably higher than the risk of the long-term complications. So for instance, I have a patient who is blind, is on dialysis, has extensive neuropathy, and he has multiple episodes of hypoglycemia if I try to achieve a goal of less than 7. So I've been a little less aggressive with him, and he's been doing a lot better, even though his A1C is around 8. Getting into slide 12, when you're thinking about where to start, like I mentioned before, lifestyle modification is really a reasonable goal, and it should be incorporated into everyone's treatment plan. But it can be the first treatment plan if their A1C is pretty close to goal, and the patient's motivated to do it. When you're thinking about starting on pharmacotherapy, you should consider, the patient characteristics, their preferences, and also the degree of hyperglycemia. Obviously, somebody who has an A1C of 12 is going to have a much different plan than someone who has an A1C of 7.2. And the ADA recommends that if you have an A1C greater than 9, you should at least consider starting them on 2 agents. And if their A1C is greater than 10, you should start them on insulin. On slide 13, I just wanted to talk a little bit about metformin, because it tends to be the mainstay of therapy unless someone's contraindicated. And so this is just a little bit about how to start it. Usually you start off with about 500 milligrams once or twice a day, and you can increase it to a max of 1,000 milligrams twice daily if they tolerate it after about a week. So they can actually titrate the medication on their own, particularly if you think they're going to benefit from maximal dose. Now, if they have contraindications to metformin, and we'll get into that in a little bit, the ADA recommends starting on either like a GLP-1 receptor agonist, sorry, it says antagonist on the slide 14. And if you want to avoid hypoglycemia, an SGLT2 inhibitor is recommended, although that's a little bit more controversial, and we'll get into that in a little bit. So on slide 15, I wanted to kind of just go over the American Academy of Clinical Endocrinology guidelines really quickly. And the main takeaway from this is that probably most people are comfortable with metformin and the sulfonylureas because they're the oldest agents. People are most familiar with them. But the AACE actually has sulfonylureas way down at the bottom as far as choices of therapy because of the risk of hypoglycemia and weight gain. And there is also some concern about increased risk of cardiovascular side effects with sulfonylureas. And so it's really falling out of favor, and we'll talk a little bit more about those in the end too. But try not to jump to glipizide as your treatment of choice. The ADA guidelines are on slide 16. As you can see, metformin is the mainstay, and then usually after that they actually don't have a lot of discretion, and it really depends on the patient sitting in front of you. So you can add another agent, you can add a third agent, and you can really consider insulin at any point of the therapy. On slide 17, this is like more than I expect you to worry about, but it does have instructions on how you would start insulin. And in general, we usually start at like 0.1 unit per kilogram per day to a max of 10. So if someone weighs more than 100 kilos, just start them at 10, and you can adjust it based on their fasting blood sugars. Okay. So there on slide 18, there's a table of all the different types of insulin. Actually, there's some more now, but we have short-acting insulins, moderate-acting insulins, and then kind of the long-acting insulins. So for the long-acting ones, we have detamir and glargine, which are most commonly used. They have a duration of action of about a day, depending on the patient. Sometimes it may be closer to 18 hours or closer to 24 hours, so you may have to use it once or twice daily. And then NPH is kind of part of the 70-30 cocktail, and it's cheap, but it does have a higher risk of hypoglycemia. And then we have the short-acting like Lispro or Aspart, which we use with meals. So on slide 19, again, I don't expect you guys to know this for your exam, but just out of just for your knowledge and when you see patients. The most important thing that you want to know is that the goal blood sugar for before meals or for fasting is going to be less than 130. So it's a good number to remember. So if their fasting blood sugars are less than 130, they're uncontrolled. If their preprandial insulins are less than 130, they're uncontrolled. Really, for primary care purposes, there's no reason to check postprandial glucose levels. And that's really more for an endocrinologist to know. Okay, so getting into some of the more specific medications, the first one here we have is metformin. As you guys probably remember, you're not too far away from step one. The method of action is somewhat unknown, but it is shown to decrease hepatic gluconeogenesis and glycogenolysis. It increases peripheral glucose uptake and insulin sensitivity. And it actually does also decrease glucose absorption, which leads to some of the major side effects, which is going to be some like diarrhea, bloating, maybe some abdominal cramping, and also it can sometimes actually lead to a B12 deficiency. So usually we check B12 levels every few years. It works really well. A1C of a drop of 1.5% is actually really good according to the ADA, and it does have some impact on your lipid profile. The major reason why you would not choose metformin is because of the worry about lactic acidosis, and so that's increased in really any sort of like low flow state. So CHF, chronic hypoxia from like COPD, and then renal or hepatic insufficiency. Um, the creatinine clearance cutoff that we recommend not starting metformin would be 45. Though if you're on metformin and your GFR falls below that point, usually we just kind of monitor very closely until you get to a creatinine clearance of less than 30. And then with CHF, again, it's not recommended to start metformin if someone has CHF, but if they develop CHF and they're already on metformin, you just really need to watch it really closely. The GLP-1 receptor agonists are actually another great medication. So examples are like exenatide, liraglutide, and dulaglutide. And that kind of, as you go through, Byetta is BID, and then Trulicity actually you can give once a week. These are injectable agents, but they work pretty well. So they work on the incretin pathway. You guys should be familiar with that as well. So they increase insulin excretion, they modulate glucagon excretion, and one of the benefits too is they actually decrease gastric emptying, which leads to early satiety, which leads to weight loss. So efficacy is moderate, so about half to 1% reduction in A1C. And then side effects are actually not too bad. Some people will get some like nausea. I haven't seen a lot with vomiting, but it has happened. Any agent that works on the pancreas, we worry about risk of pancreatitis. And then Byetta is actually contraindicated if you have a GFR of less than 30. And in some rat studies have actually shown that there's a risk of medullary thyroid carcinoma, so you wouldn't want to give it to somebody who has a family history of it or like it has a MEN syndrome. Okay, so the SGLT2 inhibitors are probably the most controversial one of the diabetes medications right now. Some examples are Invokana and Jardiance. You probably have seen lots of commercials. I actually started laughing really hard the other day because I saw a commercial and I think it was like a whole minute of potential side effects. So the canagliflozin and empagliflozin basically work on the proximal renal tubule and they block reabsorption of glucose, which leads to glycosuria. So basically you have a lower threshold at which your body excretes glucose. It works pretty well, kind of similar to the GLP-1 agonists, and there have been some controversial studies on it improving cardiovascular outcomes. The main thing that it seems to do is decrease hospital readmissions for CHF, probably because it's a diuretic and it helps with volume control. So some of the adverse reactions that were initially reported by the FDA were genital fungal infections. It's also contraindicated in CKD. But there are now increasing reports of normoglycemic DKA because you might have a normal blood glucose because you're peeing out a lot of glucose, but you're actually presenting with DKA. We've seen that a lot in the ICU recently. Increased risk of bone fractures, and now there's been actually a new black box warning on increased risk of lower extremity amputations for people on the SGLT2 inhibitors. So it may not be around for very much longer. Getting to the DPP-4 inhibitors, those are things like Januvia, so sitagliptin and saxagliptin. Basically, they also work on the incretin pathway, so they decrease the degradation of incretin, and so it leads to a lot of the similar effects. It doesn't seem to have the same effect on gastric emptying, so you don't get the benefit of weight loss, but it does have moderate efficacy, and side effects are pretty rare. I have not seen any urticarial or angioedema consequences, but it is a risk that's very small. Again, works on the pancreas, so there's a risk of pancreatitis, and there was one report of saxagliptin maybe increasing risk of hospitalization for CHF. So it works fairly well. It's nice too because you can actually it's co-formulated with metformin called Janumet, so you can actually put someone on one pill with two agents, so it's a good option. The TZDs, if you're familiar with pioglitazone, there also used to be rosiglitazone, but that was taken off the market. And so basically they work by increasing insulin sensitivity peripherally with muscle fat and liver. Works fairly well. And the main concern with the TZDs is that it can actually increase the risk of CHF. So one of the adverse reactions is lower extremity edema, and it can actually worsen symptoms in someone who has CHF. So if they have class 3 or 4 heart failure by the New York Heart Association, it's actually contraindicated to start them on Actos. There's also risk of bladder cancer that has been reported, but it's mostly been refuted at this time, so we're not really sure. And so you wouldn't want to start on someone who has an increased risk of bladder cancer. The alpha glucosidase inhibitors I never use. Basically, it's kind of like Xenical, which is like the fat blocker in the intestines that people use for weight loss. This works in a similar way where it basically decreases absorption of glucose, and so people get flatulence and diarrhea. Doesn't really work that well. People don't really tolerate it. So the sulfonylureas, again, I had mentioned those before. So some examples, are glyburide, glipizide, glimepiride. They work very well, but there's actually a decreased efficacy over time. And the thought is that you can really only squeeze a sponge so many times before it stops working. And so I've actually had a lot of patients recently who've been on sulfonylureas for years, and their A1Cs start going up because their pancreas gets burned out. Side effects, like I mentioned, were hypoglycemia and weight gain, and then there's some concern about increased risk of cardiovascular events, but the studies have not been adequately done, so I wouldn't really worry too much about that, but the hypoglycemia risk is real. And then the glutamides are the final one that I wanted to mention. And basically, I have actually never even seen a patient on it nowadays, but they're basically sulfonylureas with a shorter half-life, so they have to be dosed with meals, and so they have the same risks as sulfonylureas, and I would not recommend using them. So it kind of concludes this lecture. I apologize again that I'm not there, but hopefully this was helpful, and I really encourage you guys to ask me any questions that you might have. Happy to meet with you one-on-one, answer emails, and again, my email is chenson@mfa.gwu.edu. Thanks, guys.